Τώρα έχει αυτόν τον καταράκτη με κάτι που είναι ιδιαίτερο για μας, με ψευδοαφολίδωση. Κοιτάμε τα ενδοθυλιακά κύτταρα του κερατοειδή. Μια πολύ σημαντική μέτρηση, κατά τη γνώμη μου και τη δική μου κλινική εξάσκηση από τότε που ειδικεύτηκα στη μεταμοσχεύση κερατοειδή στο Harvard και στο Cornell στην Αμερική. Γιατί πρέπει να ξέρει ο επεμβατικός του καταράκτη πόσο δυνατός είναι ο κερατοειδής, να το πούμε απλά λαϊκά. Εδώ, μια από τις συναρπαστικές τεχνολογίες της μέρες μας, βλέπουμε στα αριστερά με το πράσινο βέλος τον ψευδοφακό, δηλαδή τον συνθετικό φακό που είχαμε τοποθετήσει στο παρελθόν και η συμπολίτησά μας, παρότι κοντεύει τα 80, βλέπει εξαιρετικά από αυτόν τον οφθαλμό. Και το κόκκινο βέλος μας δείχνει τον καταράκτη που έχει τώρα, το οποίο δυστυχώς έχει αφαιρέσει όλη τη λιουργική όραση από το αριστερό της οφθαλμό. Όλα τα υπόλοιπα νούμερα που μοιάζουν σαν τηλεφωνικούς κατάλογους, αν κάποιοι από εσάς το θυμόται, είναι παραμετροποίηση όλων των σημείων του οφθαλμού. Πιο σημαντικό, ο κερατοειδής του αριστερού ματιού εδώ, σαν φακός, με τεχνολογία που συνήθως οι συνάδελφοι την χρησιμοποιούν σε επεμβάσεις λέιζερ μυοπίας. Εμείς την αποθανατίζουμε σε όλους τους φίλους μας, συμπολίτες μας που κάνουν επεμβάσεις καταράκτη, γιατί αυτή η εξέταση εδώ μας βοηθάει να ορίσουμε τι όραση θα έχει κάποιος ή κάποια μετά από την επέμβαση του καταράκτη. Γιατί η όραση που θα έχουμε μετά την επέμβαση του καταράκτη ορίζεται από την κυρτότητα του κερατοειδή που τη βλέπουμε εδώ με μεγάλη λεπτομέρεια και από το αξονικό μήκος που είδαμε στην προηγούμενη εξέταση. Δηλαδή σε χιλιοστά και εκατοστά του χιλιοστού το μήκος του οφθαλμού. Μια βυθοσκόπηση με τη συναρπαστική τεχνολογία του όπτος. Μπορούμε να δούμε όλο το βυθό του ματιού και βλέπουμε πώς επηρεάζει ο καταράκτης το κέντρο του οφθαλμού που είναι η οχρακυλίδα. Κάνουμε πάντα μια τομογραφία της οχράς να σιγουρευτούμε ότι δεν συμπάσχει και η οχρά. Θα ήταν κάτι σύνηθες σε μια Ελληνίδα μετά τα 70 της. Και εδώ μπαίνουμε, το βλέπουμε σε ταχύτητα επί 4. Έχουμε ορίσει από πριν την 6η ώρα, οπότε τα βλέπουμε όλα ανάποδα γιατί η 6η ώρα είναι στις 12. Βρίσκουμε τον άξονα του αστιματισμού που έχουν ορίσει πολύπλοκες μετρήσεις μας. Θα μπούμε εδώ, βλέπουμε ότι η ψευδοαποφολίδωση, εδώ ο τρόπος που μπαίνουμε στον πρόσθετο θάλαμο με την κύρια τομή μας είναι ειδικός σε 2 επίπεδα. Η παρακέντηση είναι λιγότερο από 1 χιλιοστό. Το μυστικό εδώ είναι ότι βάζουμε ένα ειδικό εξοδολαστικό αυτό το τζέλ το οποίο μου δίνει περισσότερο χώρο και μεγαλύτερη ασφάλεια. Βάλαμε και ένα άλλο είδους τζέλ στην επιφάνεια και εδώ μπαίνουμε και αυτό γίνεται ακόμα και στις μέρες μας με το χέρι, ότι πρόκειται για μια manual κυκλοτερή καψουλόρυξη, γιατί έχει αποδειχθεί ότι είναι πιο ανθεκτική. Και εδώ περνάμε στήρο-ορό ανάμεσα στο κέλυφος του καταράκτη και του φυσικού φακού. Μπορεί ο φακός να μετακινηθεί. Μπαίνουμε με αυτό που λέει ο περισσότερος κόσμος λέιζερ, αλλά στην ουσία δεν είναι λέιζερ, είναι ο φακοθρηφτής, είναι η κρύα φακοθρυψία. Κάτι στο οποίο η δική μου επιστημονική καριέρα στο παρελθόν βοήθησε πάρα πολύ στο να μειωθεί η ενέργειά της και πάμε και αποσυνεργούμε τον καταράκτη σε 4 τμήματα. Πολύ προσεκτικά, με τον τρόπο που βλέπετε και ανώδυνα φυσικά για την ίδια τη συμπολίτησά μας, καθώς έχουμε μουδιάσει τους μύες του οφθαλμού και την αίσθηση από τον οφθαλμό για περίπου 1 ώρα. Η επέμβαση που θα δούμε εδώ θα είναι διάρκειας περίπου 3 λεπτών, στην ουσία ήταν 12 λεπτά για την ακρίβεια. Εδώ ξαναβάζουμε εξοδολαστικό για λόγους ασφάλειας, μπαίνουμε το εργαλείο της φακοθρηψίας που όπως ανέφερα όλος ο κόσμος αναφέρει σαν λέιζερ, στην ουσία είναι ένα πολύπλοκο σύστημα υπερήχου και αφού του έχει βγει ο καταράκτης βγάζουμε τον φλοιό του καταράκτη με μια συσκευή που έχει απλώς απορρόφηση και αντικατάσταση του υγρού. Εδώ μπαίνουμε με το αριστερό μου χέρι από την παρακέντηση και βλέπουμε πόσο χρήσιμη είναι η παρακέντηση για να μπορέσω να φτάσω σε σημεία που δεν θα μπορούσα με το δεξιό μου χέρι και είμαι δεξιόχειρας. Οπότε θέλει μια εμπειρία και κάποιο συντονισμό από τον επεμβατικό. Έχει καθαριστεί ο καταράκτης, μου μείνει κάποια πολύ μικρά υπολείμματα που θα μπούμε, θα λουστράρουμε, αν μου επιτρέπετε ο όρος, το πίστιο περιφάκιο, το οποίο θα το κάνω εδώ, γιατί δεν θεωρούμε ότι κάποιος μετά τα 70 του θα πρέπει να έχει υποδέστερη όραση από κάποιον στα 30 του, στα 20 του και στα 40 του. Έχουμε γεμίσει το σάκο του.
Hello, this is John Kanelopoulos from our center here in Athens, Greece, the LaserVision Appetary Surgery Center and Clinical Professor of Ophthalmology at NYU Medical School, New York City, New York. This is a very, very interesting case, quite rare in my career. This is a megalocornea. The cornea has diameter over 15 millimeters and has this pellucid-like picture, although it's an oblique cone. We had seen this patient many years. We recommended no eye rubbing, and you can see here how the bulging and thinning of the cornea is mainly inferiorly. The intricacy here is that I opted, instead of doing a penetrating graft, to do what you're seeing here, a circular, annular, peripheral supporting epikeratofakia. And this was a corneoscleral ring left from a penetrating keratoplasty that I trimmed the inner lips and sutured onto the cornea, and you can see how it flattened the cornea, of course, combined with CXL. And now, a year later, cataract has ensued. As you can see here, the technical difficulty here is that I have to incise through my graft here and then through the cornea as well. And I opted to go at the against the real position because that's where I had the wider view. And this is my paracentesis. The video is ×4, so I apologize for the speed. Same thing here. My paracentesis is just 1 millimeter, and everything else is pretty straightforward. Viscoat in the anterior chamber, a continuous curvilinear capsulorhexis. The visualization is relatively good, and then hydrodissection. We'll appreciate, despite the fact that this lady is just 55 years old, that due to her high myopia, the actual length is almost 30. So if she didn't have keratoconus, she would definitely have very high myopia. So I'm sculpting here. The lens, her refractive error is a -26, but of course part of that is the steepness of the cornea. So divide and conquer technique here. We can all appreciate the density of the lens, and nothing else really of note. And then we'll go in and carefully phaco emulsify each one of the quadrants. I'm going to break and replenish my viscoat around the 2 residual quadrants and the posterior capsule. Help with my paracentesis, and total 80 joules of energy used with the signature device. We're going to go in and with irrigation aspiration remove the residual cortex. Again, this is a young lady, 55 years old, and the intricacy is that she has keratoconus, very oblique cone. Many people will call this pellucid, but as we saw, this is on the grounds of a very, very large cornea, over 50 millimeter in diameter. And hi, this is John Canalopoulos from our center here in Athens, Greece, the LaserVision Ambulatory Surgery Center and Clinical Professor of Ophthalmology at NYU Medical School, New York City, New York. Very, very interesting case. This is classic Saltzman's keratopathy. We can see the white hyaline patches, if you may, in the peripheral cornea, superiorly on the side. Nice view here with anterior segment of CT. We can see that there's a delineating line separating from the stroma, although sometimes we feel that these are within the stroma when examined with slit lamp. Significant cataract in the 74-year-old lady, and the field cell count nevertheless very good. Some polymagnetism seen here. We're addressing the left eye. As you can see, a T9 lens, not available in the US, available in Europe, at the against the rule axis based on the keratometric data. My 135-degree incision, 2.75 and 1 millimeter paracentesis. Viscoat in the AC, methocellulose on the surface. Previously, this is a significant cataract. We're using divide and conquer technique. Nucleus is out, going in carefully to remove the cortex. Of course, the take-home message here is not the cataract procedure on this lady. I just want to share with you the challenging part of the procedure with these opacities in the cornea, and obviously the significant external disease that this poses to the patient. It's kind of underlined by the, and this is really something you have to do very carefully. We're using a blunt, a pre-used crescent blade, because the difficulty here is that you can find yourself within the cornea stroma. You have to find the edge, and this is a little tricky. So you can see here, this is ×4 in speed. I'm teasing until I can grasp the edge, and once you grasp the edge, you just pull it off. It just sticks away, the whole thing in one piece. It's really remarkable. And this is the take-home message from this procedure. I'm continuing with my crescent. Again, this is a crescent. The only occasion that we re-sterilize crescent blades, because I want it to be blunt. You can very easily go through stroma and do a superficial keratectomy along with removing the Saltzman nodules here. This one was partially pterygium as well. So cutting in the edge, making a fresh start. Everything looks great, but of course we have histology images here.
that we will see in a few seconds, and the confirmation. And it's very interesting to see under our pathologist microscope that there's epithelium growth over this hyaline material. And we know that this is expressed in long-term external disease, significant blepharitis, dry eye. Again here with H&A dye, the pink hyaline material, the epithelium on top. This is part of the pterygium that we had removed on the edge, a tiny pterygium. And the lens is uneventful. The problem is the patient is now a -6 and has 4 diopters of astigmatism. Why is that? Because now that we cleared the surface, we're dealing with a different cornea. And this is the same cornea that we saw before, impeccable in thickness. Everything's gone. The difference before and after with our anterior segment OCT, the OptiView Avanti angio view, and here on the pentacam, the prior and after, and you see how drastically Salzmann's had contributed to the astigmatism before, which is not present now. And the keratometry has changed, has steepened significantly. So now we have a different lens power that we're calculating, and we have to go, our success has created a big problem. We have a perfect cornea, as we can see here. You can also see that the hyperemia conjunctiva has reversed. I'm trying to track the old incision. I can find it with my Sinskey hook. A little bit more difficult in my paracentesis. It's obviously smaller, it's 1 millimeter. And you guessed it, I will go in and remove the original lens and go in with a replacement lens with a new cornea reality. We are just 3 weeks out from procedure, so I think it's the optimal time interval to come in before a synechia are formed with our lens in the capsular bag. Teasing in here with my paracentesis. I will slightly enlarge the incision from 2.7 to 3 millimeters. Very easy to go in with my Sinskey and pull out the haptics into the anterior chamber. Remember, I have viscoat in the anterior chamber, and I will place some viscoat under the lens. I will grasp the lens and bisect it with my IOL scissors, 2 pieces, and then carefully go in and pull out each hemi-meridian of the original IOL. And again, there was nothing wrong with the original procedure. It's just that these Salzmann nodules had created a cornea functional to a completely different level, much flatter and with significant wound. This is the patient, the first postoperative day, 2020 plus. Uncorrected visual acuity, and I like the cornea that I'm seeing pristine without any Salzmann nodules. Perfect reflection from anterior film, besides her being very early postoperative. John Kanellopoulos, hope you found this interesting. Signing off.
Hello, this is John Kanellopoulos, our center here in Athens, Greece, LaserVision Aperture Surgery Center. We're watching a series of cataract procedures, unedited at 8 times speed. We can tell here there's pseudoexfoliation. We're planning a toric intraocular lens. These are consecutive cases from an operating day for me here in December 2024. Manual, curvilinear capsulorhexis, hydro dissection, careful, especially in pseudoexfoliation, as well as a lot of care taken not to push the lens too much. This is where the second instrument plays a significant role in order to balance the forces when our phaco sculptor is pushing, quote unquote, on the lens. Cataract is out. Irrigation aspiration very careful here, as the cortex is quite cloudy. Make sure not to grasp any capsule, and also very important not to pull in towards the center but sideways, so to share the forces, the vector forces sideways on the zonules. Toric intraocular lens. Our go-to lens is the Clarion by Alcon. Continues the perfect material, the Acrosoft material, with less glare and no glistering. A watertight incision, case number 2, T3 lens here. You probably see every single case being toric. We have a record of over 90% toric intraocular lens placement globally, as we measure preoperative astigmatism with several keratometric measures, and we aim for half a diopter with the rule in all cases. So we even put a toric lens in a patient that has 0.25 diopters against the rule as native cornea astigmatism. The theme is the same, divide and conquer technique.
some mixed with pulling a hemimeridian here. Hydro dissection will push the hemimeridian out, back chop the half, and go on and on. Always complement with viscoat. We use it copiously in order to protect the capsule. Very sensitive part when we're left with the last quadrant to grasp part of the posterior capsule. And the split aspiration here with my incision always at 135 degrees, and this is why our formula on calculating the IOL is close to perfection. It's very rare now, even in post refractive surgery eyes, to have a surprise, refractive surprise. And in New York, we do use the light adjustable lens. It's not available in Europe, where these cases are from, but we see very low need for it, maybe one enhancement a year. Divide and conquer for quads. We can see here this is a more significant cataract. Nevertheless, we stayed with under 100 joules of total energy and again replenished the viscoat in order to protect the endothelium, no endothelial problems. If one practices this extra step that takes a few seconds, again very careful in removing the cortex with my right hand and then lefty here with my split aspiration, fill the IOP spike back to a T2 lens here, oblique astigmatism, and again, almost copies of the first procedure, always 135, incision, and at the 180 or 0 degrees if you may, a manual capsulorhexis, softer lens, will split in half. We'll lift it, back chop, and aspirate, lens is gone. Irrigation aspiration now, and polishing the posterior capsule carefully. We're going with the lefty split aspiration. Irrigation is staying with the right hand. Polish the capsule here, fill the capsule bag. And again, here's our Clarion, a T2 model here in the bag. And I left these cases unedited on purpose in order to get a good feel of the time spent for each procedure. I do place myself, the IOL, in the cartridge. I make sure that the lens unfolds, all haptics, lens is centered, axis correct. I'm coming back here in order to use myocol and attain a little bit of meiosis. This was a suspect KCN case. This is a post-LASIK case back in 1998. These are some of the first LASIK cases I did in Greece. One of my cases, obviously if it was a female, which I think this is the case here, we know that they develop cataracts before their 60s, and we advise on the same token, most younger ladies that are over 5 diopters myopic, in Greece especially, that our experience has been that regardless if they do laser or not, we expect them to develop significant cataracts, likely in their 50s. We've done many in their 40s. Again, the same theme here. Lefty aspiration, irrigation stays on the right with a main probe, polishing the capsule, and filling in with methylcellulose. Patient desired to have some myopic correction, so we're aiming dominant eye -0.5, non-dominant -1.5, and this gave us, at the end of the day, 20/20 combined uncorrected distance visual acuity and J1 near visual acuity without any problems in depth of vision or balance between the two eyes. This is the other eye of that same patient. No more cataract here. And surprise, surprise, this is probably the one case out of 10 that the keratometry and the IOL calculation based on my incision at 135 did not produce a toric lens. So a little bit more dense lens here. Again, divide and conquer. We'll complete the hydro dissection, pull out the half, back chop, cataract is out, IA, and we'll go in again with the lefty. A more dense lens here. Against the rule of astigmatism, as you can see here, technique remains the same. Everything the same. A manual capsulorhexis using your Trata, very well controlled. Again, dilatation is attained just with 5% neosynephrine drops and 0.5% tropicamide. The lens is quite dense. We're using the signature device set at 80% phaco power. And again, copious viscoelastic viscoat, and carefully bring everything to the center of the pupillary aperture, away from the cornea. Back chop here. And you saw that I replenished the viscoat prior to removing the last two segments of the lens. And again, IA from the main incision and lefty from my paracentesis. And we'll complete the procedure. Everything looks back to normal. Fold the lens. Here we go. Significant astigmatism in this patient. Our lens carries over 2 diopters of astigmatism. Under the lens, over the lens, irrigation aspiration. Center the toricity of the lens to our preoperative marks, and as you can saw, a T4 in the other eye of that same patient. As you saw, the patient comes in with a 6 o'clock mark, which is easily performed on the slit lamp. And the 6 o'clock is the lowest part of the limbus when the patient focuses straight ahead. So it's very easy to place as we come from the lower level. The patient doesn't even see the marker. They barely feel it without even anesthetic. And it's very easy to notice during the procedure. Again, divide and conquer technique. We have 4 quads, higher aspiration. And again, once the 2 first quads are gone, I'll replenish the viscoat. Our go-to viscoelastic for the divide and conquer, or the removal of the nucleus with phaco, so to speak, for decades now. And irrigation aspiration with my dexterous right hand and lefty here, staying with my right hand and come in, remove. And you can see that sticking with the routine makes everything more predictable. A fantastic result here. We aimed so better than 20/20 at distance uncorrected and a J3 at near. This patient was a hyperope, the one we just finished that second eye. We're in a new patient now. Oblique astigmatism here, same technique. Main incision, paracentesis, cystotome to initiate a continuous round capsulorhexis, hydrodissection, hydrodelineation. Spin the lens, viscoelastic under the lens. This is a softer lens, obviously, and we'll come in and take the lens all together. Back chop with our Sinskey hook. Privileged to have met Bob Sinskey back in the day when we were launching the Dodic neodymium YAG phacolysis. Our work in Europe and coordinating several centers not replace phaco, but it did push phaco to come into lower energies. And none of these cases seen today went over 100 joules. Most of them were under 30 joules in total energy used, and we're seeing here another case yet to repeat the same protocol and see step by step the special care. And although these run eightfold in speed, you can see where an experienced surgeon's attention is more on the capsulorhexis side, and experienced surgeons will understand why. Again, bring this lens all together in the pupillary aperture and remove. Come in, IA, there's almost no cortex left, but polishing the residual cortex, a younger patient here. And again, our Clarion